My name is Dr.Abdi Maalim, the County Director of Health Service, and a consultant obstetrician and gynecology working with Mandera County Government. I just want to give a brief background of pregnant mothers in the county and the importance of antenatal care to the mothers to avert some of the complications already alluded by the CC Health. Antenatal care is a care provided by skilled health professionals to pregnant women and adolescent girls to get the best health condition for both the mother and the baby. This antenatal care is very important because this is the time we are going to do what is called risk assessment for both the mother and the fetal. We do the screening for underlying conditions like hypertension, diabetic, HIV. We also do the fetal assessment by early ultrasound before 24 weeks. These visits are important because we do some preventive measures where we give tetanus toxoid to the mothers and the women. Nutritional interventions are being carried out to these pregnant mothers owing to the prevailing drought situation in the county. The nutritional health education is given, and mothers are normally encouraged to attend this antenatal clinic to avert future problems during the course of their pregnancies. Various underlying investigations done, both blood workup and other tests, to detect early conditions that normally present themselves during pregnancy. There are 4 antenatal visits currently in place, although some counties have adopted the 8-visit contact, and we encourage our mothers. They start their, antenatal clinic before 12 weeks gestation. This will help us to detect early conditions that cannot be prevented at later stage. Having given that background, I need to talk about one of the common conditions that we see with mothers in Mandera. That is anemia. Anemia is a low hemoglobin level, less than 11 grams per deciliter, and its magnitude is very high in this county, as explained earlier. This also is happening across the developing countries, with about 56% of these pregnant mothers having anemia. They are classified in terms of their severity or in terms of either whether they are physiological. There are those anemias which are common to those mothers who are pregnant. And this is majorly because of hemodilution, combination of effect of hemodilution and negative ion balances. That is the anemia that occurs in pregnancy due to physiological changes of pregnancy. There are those anemias that mothers normally get when they are pregnant. These are called pathological anemias. This is normally in our setup, nutritional deficiencies are the most common, the iron and the folic. The others are those due to increased RBC destructions, like acquired hemolytic anemias, which include parasitic infections like malaria or dengue fever. But above all, the most common cause of anemia in our setting is anemia due to blood loss. This can be acute blood loss, which occurs during early pregnancy, what is being called antepartum hemorrhage, APH. Other underlying causes, other cause of bleeding includes the chronic, blood loss. This can be due to infections, which include hookworms or GI bleeding, gastrointestinal bleeding. Who are these mothers who are at risk of getting these anemias in our setting? As we are all aware, most of our mothers give birth to many. It is called too soon, too many. This causes the depletion of iron storage in mother's body. They are called multiparous women. They are married early. The adolescence is one of the risk group of these anemias in our setting. Multiple pregnancies, twins, triplets is one of the issues that cause anemia. The other issue is parasitic infection, the way I've said, like malaria. There are complications that occur as a result of anemia if not corrected early. This complication can affect the mother, the baby, at any stage. Complications that occurs during pregnancy include preterm labor, recurrent infection, preeclampsia, and that happens during labor. We can have postpartum hemorrhage, bleeding after delivery, which can lead to shock and death of the mother. During puerperium, they can also get, puerperal sepsis, DVT, and failed lactations. The fetal complication that follows this anemia, you can get intrauterine growth retardation, or you can get death, intrauterine fetal death, or you may end up getting a low birth weight babies. Treatment of these, conditions depend on what time did the mother presented to the facility and what is the level of HB that the mother presented with. From our own, observations, we found mothers who come late arrival for treatment is common with severe anemias. That we encourage early antenatal care or visits to our mothers. We can prevent these anemias that are causing all this problem by undertaking the following interventions. We need to do preconceptional counseling to adolescents and young mothers. We need to encourage our mothers to do early ANC clinic. They start early before 12 weeks. They need to be given nutritional education and family planning method, because we need to space the pregnancy so that they don't deplete their iron stores. The second condition I want to talk, which is common in this setup, is hypertensive disease of pregnancy. This is an elevation of blood pressure that occurs during pregnancy to a mother. Starts from the diastolic pressure of 140, systolic pressure of 140, and the diastolic pressure of more than 90. They are normally classified into mild, moderate, and severe. However, for our own case, because it's a hypertension related to pregnancy, we'll talk of preeclampsia, eclampsia, chronic hypertension, preeclampsia superimposed upon chronic hypertension, or gestational hypertension, which is also called transient hypertension. Some of these hypertensions is as a result of underlying conditions. However, the gestational one is a transient. It only occurs during pregnancy. But mothers who have hypertension before, because of the presence of the pregnancy, they can get this hypertension disease in pregnancy. And it normally occurs after 20 weeks of gestation. That is 5 months. The other parameters, both laboratory and other tests that can be done to confirm these, hypertensive disorders. The most common and can be diagnosed by even, the common Manaichi, is that there's what is called eclampsia. These are hypertensive disorders which present with, seizures. We encourage our mothers to seek medical help when they see a pregnant mother who has presented with seizures. Who are these mothers who are at risk of getting these hypertensive disorders? We need to tell our public, being young, age less than 18 years, which is very common in our setting, or age more than 35 years, getting the first child is a predisposing factor to these hypertensive disorders. The second thing is there is a family history of first degree, primary, family history, where the close relatives have hypertensive disorders. There's tendency that the mother can end up getting hypertension. Or the mother herself had previous pregnancies and she had developed hypertension. She needs to be followed up. Just don't wait for the other pregnancy to occur. Medical conditions like diabetic, renal diseases, obesity, hypertension. These are some of the medical comorbidities that underlie to predispose these mothers to hypertensive disorders. Fetal risk factors include multiple gestation and other things like socioeconomic status. As we are here, this county has, the socioeconomic status is low, the dietary intake is poor. This is also one of the predisposing factors to this, hypertension. Finally, I just want to encourage our mothers to present themselves to the facilities once they come to antenatal clinics. These problems can be identified early and corrective measures can be substituted. There are those complications that these mothers get if they are not coming to the facilities early. The maternal complications and fetal complications. The maternal complication will include, which is very common, and that had occurred recently to some of the mothers whom we operated on here, is DIC. DIC is disseminated intravascular coagulopathy, where a mother blood does not clot, and you transfuse and she starts bleeding because of the bleeding disorders. You can end up getting, blindness. She can end up getting blindness or cerebrovascular accident. The fetal complication that occurs as a result of this hypertension is low birth weight, intrauterine growth retardation, or the mother can end up with abruptio of placenta, or even the demise of the baby. How do you prevent these, hypertensive disorders of pregnancy? We need to educate our mothers and the community to start their antenatal clinic early as 12 weeks. We need these checkups being done in our facilities, and we need to give some supplement within our facilities which are free, like low dose of aspirin and calcium supplement to these pregnant mothers who have tendency of developing these hypertensive disorders. In summary, I will encourage to avoid these challenges, to have safe maternal outcome for our mothers. They need to start early commencement of antenatal clinic. Hence, mothers are advised to attend all scheduled visits. There are 4 currently. We are likely to step up with the 2016 WHO model, which is 8 contact visits. Kindly advise, we advise our mothers to attend all the visits as advised. They can be referred to high risk early to make the necessary intervention. Thank you.